Well, I wanted to thank everybody for having me today. It's kind of an interesting adventure coming down here. I never thought I knew where Midland, Texas was, but somehow I found out. And it's a little bit of a reflection of the fact that when you're in Midland, the only advertisement you see in the airport are for oil rigs. Yeah. Well, I'm going to talk a little bit about Baclofen pumps and about selective dorsal rhizotomies. Been in Columbus for 2 years. We have a program that, to borrow a phrase from the recent election, it takes a village to treat these patients. And the reason being is we've actually constructed a village nationwide with a collection of physical therapists, occupational therapists, as well as our rehab folks and our neurosurgery and neurology. We have one of the only movement disorder folks trained who we just got from Case Western. So the bottom line is we have a comprehensive program that deals with all of the various things that we do at all the care related to these families. And hopefully here, when the slides come up, we'll be able to show you sort of what we do in the surgical treatment and evaluation. Oh, there we go. All right, surgical management of spasticity. We're going to talk a little bit about the definition of spasticity. I won't spend a lot of time on that because Dr. Jan has done that. We'll talk about Baclofen pumps. We'll talk about their pluses and their minuses and the kinds of things to look out for. We'll talk a lot more about selective dorsal rhizotomy, and then we'll talk about what the literature shows as far as comparison outcomes. So, as you know, cerebral palsy is one of the most common causes of disability in children. Its prevalence in the United States is about 3.5 per 1,000 live births. It's higher in males and non-Hispanic Black children. It has a significant lifetime cost, leading to effective therapies in these patients really do make an impact in these children, both in their quality of life and in the amount of health care that we end up spending. Now, first off, before, as I've sufficiently warned, we're going to talk a little bit about evaluation of a patient with spastic cerebral palsy, and we're going to use one of our patients that we ended up seeing, and you'll just kind of feel like the Wizard of Oz, ignore the person behind the curtain. But we're going to hear a little bit about her, and she's going to go through a few maneuvers. And, my daughter was very helpful in putting this video together. She was actually worked in video editing for the newspaper, so she's been able to show us some of the very specific things that she ends up doing. And as you can see, as we go through this video, which only lasts about a minute, she'll go through it. As you can see, she has very limited or no impact in her upper extremities. However, when she walks, she has a very characteristic gait for somebody with spastic diplegia. As you can see when she runs,
theoretically, those braces should make it easier for you to run.
And cognitively, she's also exceedingly smart and was quite a delight of a patient to deal with and run through this treatment. So as we move forward, and what we're trying to show is how you decide in this particular patient what you do to them. Now we have choices available to us. We can do nothing and end up with braces and Botox injections. We can do heel cord lengthenings and other types of orthopedic procedures. Or we can do Baclofen pumps and a Baclofen pump placement or a selective dorsal rhizotomy. It's important because, just so you all realize where I come from, I started my career actually doing brain tumors. And when you talk about clinical trials and evaluation of these clinical trials, that's sort of the framework with which I go with or end up treating the kids with spastic diplegia or spastic cerebral palsy. Now, spasticity is a velocity-dependent increase in tone. Well, it's one component there of open motor neuron diseases. It's an example that can also be caused by stroke, ALS, or MS. It can be divided into spinal or cerebral causes. It is considered a non-progressive condition. The decline in motor ability with age is evident, especially during middle to late teenage years. It occurs when the patients start growing, when the spasticity in their muscles begins affecting because their ability to walk, their pain, and their orthopedic deformities because the bones are growing into far in excess of what the muscles are able to accommodate. The motor function plateaus about the ages of 6 to 9. Progressive joint, muscle, and skeletal deformities develop before reaching skeletal maturity. Now, I bring this up because dystonia is another component that we see in spastic cerebral palsy. It is an intermittent or sustained, often painful twisting muscle spasm of one or more body parts. Selective dorsal rhizotomy does not end up treating this. Baclofen does. It is caused by, it often comes hand in hand with patients with spastic cerebral palsy, and it is an important diagnostic criteria that you have to end up recognizing before you decide on what particular treatment. Now, everybody knows this because we're going to talk a little bit about Asheville scores, and I just want to make sure everybody's seen this before, where you have the scores for spasticity, grades 1 through grade 5, and you can all read up there that no increase in tone, slight increase, marked, and then as well as considerable and affected rigid inflection and extension. And then the gross motor functional classification system, where you talk about, this is what a majority of the studies end up treating, where you talk about most being grades 1 through grade 5, with grades 1 through grade 3 being the people that are able to walk both unassisted and with external aids, where grades 4 and grade 5 are often the ones that walk with very maximal support or have no functional weight bearing at all. This is important because the goals of treatment that we talk about in this particular is to improve the motor activities in daily living. For those of you who are in here, when you talk about chairs, this is what everybody wants to do. You want to increase your motor activities in daily living. You want to decrease the number of trips to the operating room. You also want to increase the tone and muscle contractions by preventing DVTs, and maybe also useful in bracing these children, depending on what their quality of life is. The CP, the nice thing about these kids is most of them are minimally affected, either grades 1 through grade 3. About 30 to 40% of them are the higher grades. This last group has significant other comorbidities associated with it, and often have G-tubes and other things that they end up having to use in order to get through and develop nutrition and have all sorts of power walkers, power wheelchairs, and all other things that they have to deal with. Now, this is a chart that I like because it shows the age in which this is from Wake Forest, showing the age at which a large portion of these end up getting treated. As you can see, most of the treatment, both surgical as well as chemical, starts about ages 4. You start to see that P-per up ramp. This is because the spasticity, you end up making the diagnosis between that ages of 0 to 2. It's very difficult to make that diagnosis before, and some, you want them to continue to walk. You want to see how well they're affected during that period of time. The surgical treatments, many treatments are inadequately evaluated prior to being adopted. It's what I like to refer to as neurosurgery my way. And what the reliable outcome measures have been developed. We have electromechanical measurements of spasticity, we have gait analyses, and we also have quality of life measures. Now, with that context, we'll talk a little bit about Baclofen pump. Now, this is indicated for spasticity, in my opinion, for when you have ambulatory and poor leg strength. When your spasticity in a lot of these patients are being used to walk or is being used to walk or stand, and the ability to do this would be lost if you were to perform an SDR. It is not a common cause. It is not common for SDR to cause this problem. However, non-ambulatory patients with severe spasticity, the people that are in the wheelchair that need this as a goal of treatment to facilitate care and have significant effect in their upper extremities, this is a more common treatment that we see for patients with Baclofen pump. Now, when do we do it? These patients usually have treatment or spasticity that's been greater than 12 months. When you talk about traumatic brain injury, this is especially important because this can change when patients have traumatic brain injury. They often are refractory to oral drugs. And it's important because there's a significant complication rate associated with placement of a Baclofen pump. We often try intrathecal dosing, though that is not a prerequisite for placement of a Baclofen pump. I often think that it's also very within the standard of care to try oral Baclofen if they're able to tolerate it. It is reasonable to go ahead and place the Baclofen pump. Patients are usually older. We've pushed this envelope of greater than 4 years of age if the patients are severely affected, and the patient's weight is usually greater than 35 pounds. However, you can push it in a much lower if they're severely affected, as long as parents realize that the complication rate will go up. How do we do it? We place a lumbar subarachnoid catheter. We often place it in the low lumbar region, L4 to L5, and we're able to tunnel it up approximately to the location of C7 to T1. This is important because you're not putting these in the ambulatory patients with lower extremities. You're putting them in the patients that have effects both in the upper and lower extremities. You connect it to the distal end in the subcutaneous pocket. You often can use a Dacron pouch, but I generally don't use that because it makes the revisions and pump replacements very difficult. And you care to ensure the location of the pump is in the pocket and not under the incision. These are the kind of hardware, and as you can see in the far left picture, and what I like to tell people is, if any of you have ever been to a hockey game, this is sort of the size that you're talking about. You're talking about putting a hockey puck on somebody's abdomen, and it's important because it's going to stay there. You have catheters, and what Medtronic has done is the catheter revision rate has decreased dramatically with their new catheter that came out about 2 to 3 years ago. And then you end up having to go in and refill and reprogram this every 3 to 6 months, depending on how much your dosing is and what kind of concentration you end up using. However, I'm going to cover this with Baclofen pumps, which is why you can sense that I'm a little, sort of hesitant in these Baclofen pumps because the complication rate is high. The complication rate can exceed 30% in these patients. This is an axial contrast CT image clearly showing the catheter outside the fecal sac that I ended up revising during my time when I arrived at Nationwide. As you can see, it's not located, and the family was saying, yeah, I'm getting a little bit of an effect in the upper extremities, but not a great effect, and that's why. You end up doing this, and you pull it out and put it within the fecal sac, and again, you were able to drop the Baclofen dose by half, and the patient had extremely good effect from the Baclofen. These complications include pump underinfusions, catheter problems, including occlusion, kink, anything you can comprehend I've seen. You talk about wound, pocket erosion, incisional pain, and infection. The other big one, especially when you get into younger kids, is CSF collection, which you can get CSF that tracks around the catheter to accumulate within the pump pocket. You can tolerate a little bit of that, but as long as patients, when you access the lumbar catheter, that's what ends up happening. Albeit, you can see the catheter-related complications, and complications from the pump can reach 40%. They talk about anywhere from disconnection, leakage, catheter tip migration, especially if you have long-term pumps that end up, these kids do grow. And you can have kink or inclusion of the catheter, though with the new pump, this is decreased dramatically to where we're only seeing a few of these a year. The other important thing to talk about is Baclofen withdrawal. When the catheter does end up severing, becoming kinked, or malfunctioning, it's a medical emergency. It's a medical emergency because these patients come in with fever, hallucinations, rebound spasticities, and they itch. It's important because if you don't treat it, they can develop complete organ failure. It's important because this is something which you have to do is you have to deliver as quickly as possible. You have to deliver Baclofen into the intrathecal space to get them through this. And if you don't do this, then they can progress on to end up dying from this. Making the Baclofen pump, it's not to scare you that this is it, but it's meant that you have to come back to be at a center that's quite capable of dealing with Baclofen pumps, that's comfortable in dealing with Baclofen pumps. Because if you don't deal with it in a timely manner, it can end up becoming disastrous. Selective dorsal rhizotomy. I'm going to spend a little bit more time on this because the selective dorsal rhizotomy is a simple procedure. It was first advocated in 1908. As with anything in neurosurgery, we start this procedure and it comes with a multitude of complications. If you think this is bad, you ought to see when we first started doing brain tumor operations. That was even worse. In the 1960s, divisions of only a fraction of the nerve roots contributed to this spasticity were divided. Peacock ended up popularizing it in the 1980s. As most of you know, my mentor in St. Louis, Dr. Park, ended up modifying this procedure and only doing a 1 to 2 level laminectomy and has really taken this to the next level. What you do is you identify the nerve roots, and you decide what to section using some very selective nerve root criteria. The enthusiasm is tempered by concern about long-term effects, recognition that large uncontrolled are capable of bias towards favorable outcomes. Yet, translation, the neurosurgeon, that's the hammer for every nail, which means that we need to recognize what the general site selection criteria, and always take this to, we're still arguing about these selection criteria. We're still arguing about what is the eventual outcome, and what do we tell families when they end up undergoing selective dorsal rhizotomies. And as you can see, they need to have no injury to the basal ganglia, brainstem, or cerebellum. They need to have a degree of ambulation with or without assisted devices. Most patients are usually grades 2 to grade 3. And they need to also be able to survive or tolerate the physical therapy that has to occur after this procedure. What I want to make clear to everybody is what you do is really not that hard. The other important, the equally important thing that has to happen is the 6 months to a year of therapy that has to occur after the procedure. Because if that doesn't happen, what I do makes absolutely very limited amount of difference. The patient selection, spastic diplegia, limited to no upper extremity or vulnar spastic quadriplegia, independent mobility with or without assisted devices, greater than 2 years of age. Again, question the CPU diagnosis if less than 2. We onset in infancy with progressive improvement and not deteriorating during preschool years. Preoperative evaluations that we end up doing, we talk about hip subluxation or dislocation. It's not a classic preterm infant. We end up getting a brain MRI or even spine to make sure we don't have evidence of tethered cord. We can do in some of the other ones do gait analysis to verify and really characterize the spastic diplegia and to evaluate post-op progress. They cannot have fixed orthopedic deformities because that will affect our outcomes after dorsal rhizotomy. We talk about, in doing the selective dorsal rhizotomy, we talk about partial deafferentation. We generally cut between 60 to 75% of these nerve roots from L1 to S2. We do EMG testing to see if we can identify and cut the ones that are the most affected. We generally do this in a single to 2 level laminectomy, the minimally invasive one that Park ended up prescribing out of St. Louis. We do ultrasound. This occurs because you can ultrasound localize the conus, and that's the most critical thing, as I'll show in one of my intraoperative videos. How do we do this? We position them so with their head down, doing a small laminectomy and small incision on the back. We end up looking through the intraoperative ultrasound in intraspinous space, as shown over on the right side of the. And if we're able to visualize the conus, that's what we need to divide the dorsal from the ventral nerve roots. It's that division that I'll show you in the next intraoperative video. Go ahead and start the video. That we're able to manage this because, as you can see, again, my daughter was quite. What it is it looks like it's sort of spaghetti management for those, and they made sure to promise that I would do this before lunch. But it's equally important, as you can see, this is a caudate quinage, and unfortunately the nerve roots did not come labeled with the, cut me kind of situation. So we have to figure out which ones are the sensory nerve roots and which ones are the motor nerve roots. And we do this because, as you can see, what we look at is upward on the right, you can see as one of the nerve roots exits the neuroforamen, and then the one in the lower part is going to be the ventral nerve root. That's the motor nerve root, and the one on the upper is the dorsal nerve root, or the sensory component of this. So that's great for the one that's exiting. This is why Peacock did it, is that he can merge through each of these levels, and he can absolutely tell what's the dorsal nerve root and what's the ventral nerve root. No questions about it, right? Well, you'll add electrophysiology to this and a little knowledge of anatomy, that everything below that level is ventral, and everything above that level is dorsal. That works 99% of the time. But as you can see, what I'm here developing is I'm developing the plane between those areas, because your ventral nerve roots will end up dividing out at the level of the conus. Go ahead and advance it a little bit. And what we're doing here is, you can see that there's the tip of the conus, and for those of you that have seen it for the first time, that's what the spinal cord looks like. And what we're doing is that the last of the motor nerve roots were ended up dividing out, and you can tell based on the size. You end up dividing out and end up getting back into where your cotton is on the other side, and you can divide out all the dorsal nerve roots. If you go much lower, this is where one of the complications can arise. You talk about contributions to the bladder. So if you don't adequately divide these out, you can end up with bladder dysfunction after a dorsal rhizotomy. And what you end up, this is one of the valuable inputs for electrophysiology, because they're able to tell you what nerves you end up, with a certain degree of specificity, they're able to tell you what nerves you end up, what nerves you're stimulating. And here I am trying to find the last of the nerve roots, and anatomically the way it's organized is your upper ones, or your L2 to L4, are the ones that lie out there laterally. And what you're trying to do is determine, both with your spontaneous EMG that you see during this, you're trying to determine whether that's a sensory or motor nerve root. That's actually the exiting nerve root as it goes through the neuroforamen on the other side. So we'll end up grabbing that and go ahead and advance it a little further. So now this is how we do this. So we take each of the various fascicles and we end up dividing them out, and easily. And this is a big reason. So for those of you who have undergone a dorsal rhizotomy or thinking about it, they end up having a lot of neuropathic pain afterwards. They end up having a lot of neuropathic pain because this is how you end up dividing out the nerve roots. This usually occurs within 1 to 2 weeks after rhizotomy. Here we are stimulating it, and that little twitch is not me shaking. It's actually the muscles of the leg contracting when they end up being stimulated. This is important because what you can do is sometimes isolate or identify specific rootlets or specific components of that nerve that are contributing to the spasticity. And as we move through this, we go through each of the various sides and then end up cutting the exiting nerve roots as we move out. And as you can see, it leaves a majority of these nerve roots are sectioned, about 60% of them, meaning it's very easy to cut to, say, 1. And we try to anatomically get between 60 to 75% of these nerve roots sectioned. So we'll move on to the next one. So the way we do this is our electromyographic response. This is the same thing that we did in St. Louis. What we look for is the ones that are 3 to 4 plus, which are sustained discharges from contralateral muscles, with or without sustained discharges from the ipsilateral muscles. When you see these, you end up cutting them. Well, the first and foremost thing, and all the studies that have been undergone with a dorsal rhizotomy really section that you have to take 60% or greater of the nerve roots. So I will take 60 plus percent of these. But these are the ones we end up sectioning for sure, because they're the ones that are the primary contributors to the spasticity. And what that does is that ends up, go ahead and treat it. That ends up, so to personalize this a little bit, go ahead and hit the next one. This ends up turning this one, and again, ignore the person behind the curtain. And what that does is that ends up turning somebody who walks like having some significant problems with spasticity and problems with running and problems with isolated muscle control, but is exceedingly motivated and exceedingly willing to work with physical therapy. It turns her into somebody who has isolated muscle control and has a very, a much more normal appearing gait. And for those of you that are coming, this is a very, you can see the muscles in the knee are more isolated in movement, and the spasticity that was clearly occurring or interfering with gait beforehand is essentially gone. This is important because this is in the very immediate post-operative period, and she did very well. So the way we do the selective dorsal rhizotomies, or the way our care is done, is we do this post-op, IC or floor observation. We actually place epidural catheters for these patients, and that significantly has helped with our pain management. And in the older patients, we end up making sure that these patients go to the floor. We convert to oral analgesia by post-op day 2 or 3. We usually are flat for 3 days. where therapy begins between postoperative day 2 and day number 3. And by day 5 to 6, we end up transferring to rehab. This is where the variability in PT care can occur depending on what center you go. Some do anywhere from 2 to 6 weeks of inpatient care. If you go to Gillette, they're going to do 6 weeks of inpatient care. By about 2 to 3 weeks, I think that most patients usually get tired of seeing me, so I usually, no, usually we do between 2 to 3 weeks of inpatient care, because what that does is that gets the patient started very early. It gets them off on the right track. It gives them a resource to be able to utilize this when they go home, and gets the pattern with therapists that are comfortable working with patients with spastic diplegia. Now, everybody doesn't have the same kind of resources that you have down here in Texas, so that is exceedingly important. Others do 6 weeks of outpatient care and 5 days a week. So none have been able to show which is right. These are just the options available to the families. This is our peri-op pain control management. This is a retrospective study of 31 patients receiving epidural anesthesia and 41 receiving systemic analgesia. The epidural anesthesia patients had a significant reduction in postoperative pain scores. This was one of our this is from St. Louis, but it's one of the most important things that we did in really treating these patients. We had fewer periods of desaturation in epidural patients. Translation, we didn't give them as many narcotics. This provided better pain control and allowed them to begin participating in physical therapy and not having the same sort of constipation that you see after somebody's been given morphine or Demerol for a prolonged period of time. Now, what we've been able to do is our clinical program, we've developed a national referral base. We are a network site for the recent collection of centers trying to look at spastic cerebral palsy or spastic diplegia. We are beginning to start comparison of therapies. We are working on our gait lab in partnership with Hyundai and really working on our patient selection criteria, so we can really, with science behind us, be able to talk with families of what they can expect both before and after the various therapies. These benefits are a permanent decrease in spasticity. There's no loss in motor with sustained improvement in gait. You do have a dip after this because patients need to be retrained. Once the tone is gone, they need to be retrained how to walk. And you will have a decrease in function prior to your increase in function as the strength improves. We do have improvements in scores. This persists long-term at 1, 5, 10, and 15 years. You do have a reduction in orthopedic surgeries. You do not have an elimination in orthopedic surgeries after performance of the selective dorsal rhizotomy, and durable improvement in lower limb tone, gross motor, and performance of ADLs. These complications, everybody wants to know what happens. What are your complications? If you have sensory disturbances, you can have about a 10% risk of spinal instability, paraplegia or incontinence, CSF leak, or an infection. In practice, what we're only seeing is patchy sensory loss, which usually resolves after 1 to 2 weeks. You get improvement in the ambulation and motor capabilities. You have the traditional technique versus a minimally invasive technique, and hopefully reducing the amount of spinal deformities that you see after this procedure. Now, this is probably the biggest set of collection of studies showing what selective dorsal rhizotomy can do. This is a meta-analysis of 3 randomized controlled trials. And what it shows is, this is from Vancouver, Toronto, and Seattle, showing that you do get a decrease you get an improvement in your spasticity in patients in these randomized controlled trials. This showing a change in scores for your gross motor scores as well as your tone, all showing an improvement or a improvement in the spasticity of these kids, showing the benefits of selective dorsal rhizotomy. These pooled ASHRA scores confirmed an overall reduction in spasticity in SVR plus physical therapy patients. These pooled results also confirmed that the SVR and physical therapy result in an improvement when compared to physical therapy alone. Leading to this is a collection from the recent Ontario group, that collection of experts showing recommendations that occur with strong evidence suggesting that you should be doing this in ages 4 to 7. Weak evidence greater than 7, not recommended in evidence less than 4 or greater than 8. Not entirely, accepted by everybody, but I'm just putting out there because these are the recommendations that experts are putting out. The gross motor scores of grades 2, grades 3, generally not recommended in grades 4 and 5, but again, I'm going to show you some things that show that's up for discussion. And again, the movement disorders, when it's all spastic, when not recommended with those other things such as dystonia that are components of a particular patient. Other potential indications for SDR include spinal cord injury, hereditary spastic paraparesis, adult stroke. Although people need to recognize these are only small case reports or small case series, where again, what I like to refer to as neurosurgery my way. Now, with that said, rhizotomy or Baclofen pump, everybody would agree with this, that most in grades 2 to grade 3, this is a pretty good indication for selective dorsal rhizotomy. Where the discussion ends up being is we're talking about in the higher grades, in grades 4 to grade 5. I wouldn't go so far as to say it's not recommended. But again, in these particular patients, as with anything, when you undergo surgery, you need to establish a partnership with the families and discuss realistic expectations, because that's very important in deciding what you end up, where you end up going. This is a study showing 10 patients with severe spasticity scheduled to have their Baclofen pump replaced because of either the pump life or because of infection. They ended up undergoing SDR. And what 90% of the patient's caregivers thought SDR was functional outcome was improved when compared to intrathecal Baclofen. We had also improvements in neurologic function in 27% of these patients, at least suggesting in a very small case series that there was, when you start comparing Baclofen pumps to SDRs, that SDR was a little better in the severely affected children. Orthopedic procedures can also, tendon release and lengthening, as well as osteotomies. Other neurosurgical procedures, intrathecal phenol, ethanol, DRES, as well as a variety of other ventral spinal cord gray matter or ventral rhizotomies is also being done. This is surgical treatment for spasticity in children and compared to selective dorsal rhizotomies in both ITB versus SDRs. This is done out of Utah. These are 71 consecutive patients who underwent SDR. They sort of chose their patients when SDR was available in Utah. What they did is 71 with SDR matched with 71 who underwent intrathecal therapy, ITB therapy. They're matched by age and motor score. What they showed, they looked at changes in Ashworth motor scores as well as parent satisfaction. And bear in mind here, in this particular study, they included these patients with scores of 3 or higher, basically the more severely affected. And what they showed is that SDR provided a larger improvement in tone, passive range of motion, and gross motor function when compared to these patients with ITB therapy, at least suggesting in this limited study section that when you compare SDR and the more severely affected kids, there is some potential for benefit. Fewer patients in this group had required orthopedic procedures. Both procedures, however, had a high degree of patient satisfaction, and I think the intrathecal Baclofen also, as long as parents recognize, they need to come back to physicians to make sure that you have you basically head off any of the complications before they happen. Now, these advantages of SDR: fewer surgeries, no battery changes and complications, fewer returns to physicians, you don't have to come back for the every 3-month refills, and a potentially lower cost to patients, some of the researchers are potentially looking at, including us at Nationwide. Advantage of ITB therapy: it is reversible. You can take it out if it doesn't work. It can be titrated depending on the need, whereas the SDR is once you do it, you're done. In summary, we'd like to show that tone reduction is absolutely necessary. These two procedures are options for spasticity treatment. These SDR results are durable and complications are rare, but they do occur. And further studies directly comparing each of the therapies need to be done. And we also need to be able to talk with families about what's a reasonable set of expectations, both before and after SDR. Now with that, let's talk about the other video. And she actually went several weeks after SDR. And as you can see, a highly motivated individual can do this. And what you see is the same sort of thing as I was able to show with the other patient. Isolated, a very normal appearing gait in somebody that is really doing a wonderful job. And we kind of have a football field for a hospital, and she walked all over the hospital. A sign of what a motivated individual can do. And both sisters are motivated, and both sisters are doing very well after their SDRs. And with that, I'd like to say thank you for your time. And I'd be happy to entertain any questions, both at the Q&A or whenever Dr. Jan says.